Good morning, everyone, and welcome to the 2025 Leap into Advocacy Virtual Summit. I am Sarita Edwards, the CEO and President at the E.WE Foundation, and I am honored to have you be here to help us kick off today's event. Whether you're joining as a patient, a caregiver, a healthcare provider, a researcher, a policymaker, or a rare disease ally, thank you so much for being here and for your commitment to advocacy, equity, and policy impact. So this year, our theme is innovation and collaboration, leveraging data to transform rare disease advocacy. This theme reflects a growing and urgent need in our community, and that's to connect the lived experience with data and evidence that drive real world change. Today, you'll hear from experts in advocacy, maternal and child health, and mental health who are doing just that, making change. We're also going to explore what happens when we combine personal stories with data to create solutions that can work for the greater good. So a few housekeeping notes before we get started. This event is approved for 2 CEUs. And so if you indicated during registration that you're interested in these, once we confirm attendance, you'll receive a certificate via your inbox. This event is being recorded. You can find the replay after today's sessions on our YouTube channel. Closed captioning is available throughout the event. You can enable that by clicking the CC button at the bottom of your screen. We will have time for Q&A during each session. We'll respond to those questions in real time. Use the Q&A box at the bottom of your screen. You can also feel free to use the chat. But to make sure we don't miss anything, put those in the Q&A. If you experience any technical difficulties, please send a message in the chat and we'll try to make sure we can accommodate you for the duration of today's event. So let's get started. I'm going to actually lead the first session on leveraging data to drive impact using stories to shape policy. So for this session, my focus is on state level advocacy and why this type of advocacy is so important. So let's start by talking about why state level advocacy matters. States are often the decision makers when it comes to health services, Medicaid coverage, education, newborn screening, issues that directly impact our families. Because of this, state advocacy, it gives us a faster, more targeted way to create change. State decisions can also set the tone for national policy. And so there are 3 key areas to pay attention to. Legislation, these are the laws that create or expand programs. Budget appropriations, this is where we find out what the state values because funding priorities tell us the truth. And administrative rules and policies, these are agency decisions that shape how laws get implemented on the ground. And so understanding this landscape gives us a roadmap for where and how we're able to show up. One of the most powerful things that we can do is to combine data with our storytelling. And so stories, they move hearts, right? But data moves systems. And so that means we need both, right? When you share your personal journey, anchored it in statistics, talk about how many others are impacted with your condition, what the outcomes are, and where gaps in access might exist. Your story can highlight trends and individualized care opportunities, care coordination that's been overlooked. And so you can use things like local statistics, disparities and access gaps, economic and health outcomes. All of these things can impact how you share your story. Your story then becomes more impactful when it's supported by this type of data. So if you can't find data that reflects your experience, consider building your own. You can start small, but be strategic. Host a listening session, distribute a brief survey, conduct interviews with other families. This kind of community generated data is valuable. Again, it helps to identify trends and highlight gaps that formal systems may overlook. At the E.WE Foundation, one of the ways we did this was through our Trisomy 18 newborn screening access and education survey. We sent out a cross-sectional survey that's now giving us real insights into newborn screening experiences for families in our patient community. And it's helping us shape our advocacy goals as an organization. So I do want to be clear that you do not have to write legislation to make an impact. I think a lot of advocates feel less effective if they don't create a bill of some type for their patient community. But I want to highlight that there are so many ways to be an advocate, to be effective, and to get involved. You can join coalitions. You can sign on to letters of support. You can educate your legislators, testify at a hearing, and you can share your story on so many different platforms, including your own personal social media. Advocacy isn't a one size fits all event. Every action that we take can move the needle forward when it comes to advocating for families impacted by rare conditions and medically complex diagnoses. So collaboration in action, when we think about the power that comes with collaboration, collaboration truly is the fuel for sustainable change. Each of us brings something to the table: policy expertise, lived experiences, communication skills, grassroots reach. When we align all these people, all these key stakeholders, when we all come together, we multiply our impact. We have seen firsthand with initiatives around newborn screening, special education access, Medicaid expansion. We've just crossed over into maternal and infant health. And working together is ensuring that no voice is isolated and that no effort is wasted. And so it's very, very important to consider um, working alongside other organizations who are looking to drive change and impact when it comes to state level advocacy and even federal impact. So knowing when to say that, knowing when to say yes, with that, not every opportunity is a good opportunity, and that's okay. When you do decide to engage, I recommend asking yourself a couple of questions. Does this align with our mission? Whether that's, you as an organization, or if you are an individual, or if it's your personal family goals. Does collaboration with a specific organization align with what you want in your rare disease advocacy? Will it help the families that you serve? Or, you can consider making it a personal question. Will this help a family like mine? Will it help my own family? Um, who are the other stakeholders involved? What other groups support this work? Are they reputable in the rare disease space or in any space? It sounds like a lot, I know, but I think being strategic protects you. It also protects your energy, and it keeps your advocacy aligned with your goals. And so I think it's very important to make sure that when you are supporting bills and legislation and adding your name to um, different projects, that the people that you're saying yes to. So what's next? Advocacy starts with one step, honestly, and it grows however you want it to grow, however fast you want it to grow. Start with your story, because that's what you know, and you know it well. It's not something that you have to learn, but it may be something that you need to craft and perfect. I have been on our advocacy journey for 9 years. So I have 9 years of lived experience, but I don't always have the time to share those 9 years of lived experience. And so I think it's important to craft our stories to accommodate the time that we have, the reason that we're sharing it, and then who we're sharing it with, and really craft your story for that audience in that moment, which means you may have to change it from time to time, and that's okay. You may have to alter or modify what you share in any given scenario. And so I think we have to consider what pieces of our story are we going to share at any given moment. Learn who your state legislators are. Start by learning your legislative calendar. This can be different from state to state. Um, know who's in your district and who's representing you. Who are you a constituent of? Identify your local champions. Don't assume that a lack of interest or support right now means that there will never be interest or support. The work that we do is bipartisan. That's something that we hear a lot in this space. And so sometimes our champions may not come immediately from someone, but sometimes those champions can come from unexpected spaces. And so I say keep yourself open to building those relationships. You can join or build a coalition. See what's happening in your community. What's important to other individuals and organizations. Is it something that you find valuable that you want to support and be a part of? And then collect your data. Starting with your story, collect the data around you. Check out public health websites and different organizations and see what everybody is talking about to see how you can pull that to your story. The key here is really to get started. Every big movement starts with a single voice. And in a lot of instances, that voice could very much be yours. All right, so that is it for me. I want to thank you for your time and attention. If you'd like to connect with me, this is my contact information on the screen. I'm always open to collaborating and supporting advocacy efforts that align with the work that we do. So please don't hesitate to reach out. I'm actually going to stop sharing to check for questions. Um, and then let's see, let me just respond to some questions that we got during registration. So the first one was, what are some best practices for advocates who are unsure how to collect or present data to support their personal stories? Um, I think that's a great question, and it's a question that we hear a lot. I think it starts with knowing your story, and because that's what you know it well. Your lived experience is a form of qualitative data, so you can track key moments of success. You can track moments where access or costs or specific outcomes were affected. Those are all data points that you can share. I think you can use existing data from local or national reports that can provide statistics that help you frame your story. So, for example, only 5% of rare diseases have an FDA approved treatment. Well, my son's condition, trisomy 18, is part of the 95% without a treatment. So I can use that in conversations. Connecting the emotion to the evidence. And so I think that's a really, really great place to start. And then just one other question was how can we ensure that policymakers give equal weight to patient stories as they do clinical or statistical data? You know, I think I think a lot of policymakers are interested in patient stories, and I think they want to know about the lived experience. But I also understand uh, feeling like lived experience is viewed as less valuable. I would say again, position your story with the data. Say things like, "I'm one of X number of families facing this," or "This is a recurring theme in our community." The latter statement, actually applies to us. my son's condition is medically termed incompatible with life. And so in a lot of healthcare spaces, that's the narrative. And so I can use that when I'm having conversations. Combine your story with the statistics, similar to the first question. I think what I want us to take away from this is that stories give insight into the barriers and the behaviors and the real world impact, things that, some quantitative data um, often, won't capture for us. And so I think wherever you find yourself, whether you're sharing your story with the legislator, if you're giving a public testimony, if it's a one-on-one meeting with another key stakeholder in the space, I think, you can create space for your story to lead those conversations. And so feel free to, if you think of any other questions, those who are joining us, you can put them in the chat or in the Q&A. And then we're going to go ahead and move forward with our next session. We are very much ahead of schedule, but that's okay. We're gonna keep things moving and keep the party going. So I'm gonna share my screen one more time. So for this session, we are actually going to answer the question, where do I begin when it comes to advocacy? Whether you're brand new to the advocacy space or you're looking to sharpen your skills and your impact, this is the session for you. We are honored to welcome Kendly Jones, the RDLA Program Manager at the EveryLife Foundation for Rare Diseases. Kendly works closely with rare disease advocates across the country, helping them understand policy processes and empowering them to raise their voices with purpose and clarity. Today, she'll walk us through how to navigate the legislative process, from drafting and supporting bills to preparing testimony and understanding how to advocate at both state and federal levels. And so please join me in welcoming Kendly to our virtual stage. Kendly, it's all you.
Thank you so much. It's a privilege to be here today, and I'm so excited to speak with everyone. Like Sarita said, my name is Kendly Jones. I am the RDLA Program Manager for the EveryLife Foundation. I will be covering advocacy, and hopefully we'll be able to learn something together. If anyone does have any questions, I am happy to answer those after the presentation. So we can go and move to the next slide. Perfect. Another overview of we're going to do policy and advocacy. So a little bit about the EveryLife Foundation. We are a nonprofit, nonpartisan organization that is dedicated to empowering the rare disease patient community. We hope to encourage everyone to advocate for impactful, science-driven legislation and policies that advance the equitable development and access to life-saving diagnoses, treatments, and cures. The programs that I run are part of the Rare Disease Legislative Advocates Program. It's kind of under the umbrella of EveryLife Foundation, but if you see either of those, that's us, and we love when anyone gets the opportunity to be a part of one of our programs. So yeah. Okay, so we'll start with just what is advocacy? Advocacy is defined as an activity by a person or a group of people to influence or change decisions made by the people who make our laws. And when you're starting your advocacy journey, it can be very daunting and very confusing to try and identify legislation to support, because there is so much happening all the time at the state level, local level, federal level. It's a lot to jump into, and it can be very confusing. So when you are considering which bills you want to support, these are just a couple of tips you can follow. So it's always important to remember again that rare disease is a nonpartisan issue. So bills that benefit the rare disease community can come from any legislator. And then when you're looking for those bills, you can generally visit your state's website or congress.gov. The state website will obviously be for your state government. Most state and federal pages have a search function where you can filter by topic or by word, by keyword. Each state's website is going to look a little bit different, but they do generally have those functions where you can search things like priority review, you can search things like insurance issues. And then also when you visit, if you want to look at committee specific pages on the federal level. You can visit web pages for state committees, or I apologize, for committees like the Energy and Commerce Committee, the Senate Help Committee, the Senate Finance Committee, etc. Most of the time when you're going to look for a state committee, you'll generally go to the state's health committee. But if you have any questions, that's a great opportunity to reach out to your legislator and ask them questions about where certain bills are going. So you'll also want to look at bills that are assigned to those specific committees that you are interested in. Generally, if you go to a committee webpage, it'll show all the bills that they are reviewing. And if any of those are bills that you're interested in, you can reach out to those committee members, or you can reach out to your representative to express your interest and share your desire for their support on that legislation. Another great way to identify bills to support is watching or reading your local news. Often they will bring up that bill number and link it. If you are interested, you can click on that link and learn more and read more about the legislation. You can also watch your legislator's webpage and or social media to see what bills they are focused on. And you can work with rare disease organizations like the EveryLife Foundation or the E.WE Foundation or any other rare disease specific organization that is watching policy and can keep you informed on bills that might impact you and align with your needs. So once you identify a bill that you are interested in supporting, generally you will want to share your story with a legislator and share why that legislation will make an impact in your life. So what does that look like? These are some tips for meeting with your legislator. When you meet with them, generally there will be a tighter timeline for the meeting just because they are so busy. So you want to be sure you get lots of good stuff in a smaller amount of time. So what that looks like is you'll take about 1 minute to 2 minutes to share a little bit about you. That can be your rare disease, your diagnostic odyssey, where you're from, what you do for work, your age, anything like that that's going to make that initial connection with your legislator and tell them a little bit more about why you're meeting with them. And once you identify, and then after you share a little bit about yourself, you're going to identify a problem. And that problem is addressed in the legislation that you're interested in supporting. So you're going to identify that problem and then identify the solution that's present in the bill. And then you're going to make that ask. And so making that ask is asking for a specific action that your legislator can take to show their support. So that's something like voting in favor or co-sponsoring the bill. So if I were to ask for Senate Bill 123 to be passed, I would share a little bit about myself. I would identify a problem, and then I would show how Senate Bill 123 has a solution to that problem. And then finally, I would ask my legislator to either co-sponsor or support Senate Bill 123. And remember, when you are meeting with your legislator and sharing your story, you want to be concise. Less is more, because if you have more opportunity for questions and discussion at the end, the legislator is going to be much more involved in the discussion. You want to do a good job of balancing fact and emotion. It's important to have both in there, but to have a good mix. You want to be authentic, and then there's no need to memorize everything. You're in there to share about yourself, and you're the expert on your condition, and so you are there to just talk, just have that discussion with your legislator, and there's no need to have everything memorized word for word. Perfect. So now that we discussed what it looks like when you're meeting with the legislator, what are some other ways that you can advocate? So you want to create relationships with your state and federal lawmakers, and we will go a little bit more into detail on this. So you'll want to share your story with a policy or legislative ask. At the end of meeting with your legislator, you'll want to ask questions and have a conversation where possible. Again, if you can get a legislator or a staffer involved in a conversation, that's going to stick in their head a lot longer, and then they will be able to have a little bit more information. And so it's always beneficial if you can ask questions and have a conversation with your legislator. Again, we want you to engage with organizations that support you. They'll have policy resources a lot of the times and do the heavy lifting on finding legislation that's going to impact you and be able to provide information generally. You also want to support others with their policy goals when they align. This is a fantastic community and it's a very supportive community. So when possible, we want to support everyone. And then activate your network. Contact your friends, your family, those you interact with in your community. You have a network, and that is a whole group of people that is willing to rally around you and support you. Perfect. So like I mentioned, we're going to go a little bit deeper into how you can create relationships with your lawmakers. These are just a few ways you can meet with your legislator in person or virtually. The EveryLife Foundation does run several programs throughout the year where you have the opportunity to meet with your federal and or state legislators in their office or virtually. You can also research your legislator's website or social media to learn a little bit more about them. So when you're meeting with them, you have a better sense of the topics that they are interested in, or you can make those personal connections, like maybe you're from the same city, maybe you both love to golf or something like that to make a connection with them. You can invite your member of Congress or their staff to attend events in your community, or you can attend theirs. There are many legislators who hold town halls or fun events in the community to get to meet with their constituents. So that's a great opportunity to go meet them and start establishing that relationship so you can discuss about important policies as you continue to develop that relationship. You can write a letter or email to your lawmakers. Your lawmaker's email will usually be on their webpage in the state or federal website. And so will their address. So if you need that information, that's a great way to find it. You can call your lawmakers' offices to share your story or to express a desire for their support on certain legislation. And then we always want to make sure to send a thank you message, whether that be a call, an email, a letter, or a social media post, when your lawmaker supports rare disease issues, because we want to make sure that they know that we appreciate their work on behalf of the rare disease community and that we see it and we acknowledge it. Perfect. So this was a study that was done a few years ago, and it shows why relationships matter. And you can see a bunch of different ways that people get in touch with their legislator, but up at the top, those in-person visits from constituents, and I'll extend that to Zoom because it's a new world where we get that opportunity to meet with them via video chat, but 97% of those visits from constituents were at least somewhat impactful, if not extremely impactful. So we see that that is the highest level where we can create that connection that it makes the most difference. So this is just a really good visual about why it's so important to reach out to your legislators and what an impressive impact that you can have just by meeting with them. Perfect. So that was a little bit about what it looks like when you identify a bill and you want your legislator support on that bill. But there are cases where there isn't a bill that exists that would address the problem that you've identified. So how can you determine if a law needs to be created and what can you do about it? So if you identify an issue in your local or broad community that could be improved upon by legislative action, so that's something where it can be addressed by law, consider the following. Is this something that already exists in state or federal law and potentially could be improved by an amendment or something like that? So consider if it already exists and what that means for your next steps. Is it something with a clear action item that you can bring to a legislator? So legislators have so much happening on so many different topics, and it can be difficult to create a specific action item if something general is brought to them. So if you come to them with a specific ask, it makes the process a lot easier and a lot more straightforward on their end. So how can this problem be solved? By legislation, regulations by an agency, etc. That's something you need to consider before you bring a proposal to a legislator. Consider where you live. Every state has different laws and processes. Also, if you live in a more rural location versus an urban location, that is going to change your local law. So just consider where you live and the impact that that has on the potential legislation. And then you'll want to identify other stakeholders who are impacted by the issue and learn more and collaborate. So the more organizations, the more constituents, the more individuals that you can get involved, the better, the more voices that you have to contribute towards bringing forth that legislation. And then as an example of why it's so important to consider all these factors, if you're interested in bringing the insurance issues to your legislators, you can consider that there are many types of insurance. There's employer-sponsored, there's direct purchase, there's self-funded, Medicare, Medicaid. There's so many different types of insurance issues. So if you were to come to a legislator and just broadly state that you would like to address insurance, that can be confusing and not have much direction. So you want to do research on the back end so you have specific action items and you're ready to go when you do meet with that legislator and determine if a law needs to be created. So what should you consider when you're working with a legislator to create those laws? So legislators do have many constituents coming to them with ideas for legislation that can be very overwhelming for them and their staff. So it's good to do that work on the back end. And then you want to focus on establishing a relationship with your legislator and becoming a resource for them. So this is important if you are looking to create a new law or if you are looking to support certain legislation as a constituent. If you're someone that a legislator can think of that as someone who can advocate for the rare disease community when they have questions, that's a fantastic place to be. If they can reach out and say, oh, I know that, they will be someone who knows a lot about this subject. I'm just going to go ahead and ask them. That's a really impressive and important place to be. So also, it's important to consider that passing legislation is difficult at every level and it's extremely complicated. A bill can take years to pass. So often when you first bring an idea to a legislator, that's just the start of the process. And it's important to keep trying, and it can be extremely discouraging, but just know you've thought this through. And if something doesn't happen the first year, you can try again the next year. So we encourage you to keep trying. And finally, the more information on the issue, how constituents are impacted and how to solve the problem, you are able to share with the legislator, the better. So the more information that you have, that's going to be the best case scenario when you do meet with a legislator and discuss potentially creating a new law. So this is a visual of what the process of a bill looks like at the federal level. So it is fairly similar to a lot of states. Every state is going to have their own process. If you do have a question about that, you can reach out to your local legislator. But at the federal level, a bill will start in either the House or the Senate, and then it moves to committee, and then it goes through these hearings that you see and these different processes, and then it moves to the other house. So like I mentioned a little bit earlier, there is a lot that happens to a bill when it's introduced before passage. And so it's important to just stay diligent as you go through each individual process and as you learn more about the legislative process. Perfect. So that was a lot of information and it can be a lot to digest. But what other tools do you have available as you want to learn more? On our website, we have policy primers. So this is a informational sheet about legislation that would impact the rare disease community. We also have legislative scorecards by state. So you can click on your state and see the current legislators at the federal level and see some examples of rare disease legislation and if they voted in favor or against or were absent, things like that. And then we also have tip sheets on a lot of subjects, some of which are advocating and congressional appropriations, how to schedule a meeting with your legislator, and a little bit more information on fostering a relationship with your member of Congress. Perfect. So a few more examples of advocacy. You want to contact your lawmakers when you disagree with something they support or want to bring an issue to their attention. You can do this through phone call, email, meeting with them in person. There are a lot of ways to express your opinion and share your story. You want to attend events your elected officials hold, like town halls. This is a great opportunity in a smaller venue to share your story. You can create a petition, you can attend a gathering, you can send a postcard, letter, or email to your lawmaker. And again, we want you to meet with your lawmakers in person or virtually where possible. You can do this by contacting your lawmaker's office directly. When should you advocate? Anytime and all the time. So you can schedule in-district meetings during district work periods. So for the state, at the state level, generally, that does look different for every state, but generally it's the first few months of each year. That's a great time where you can express your desire for their support or your opposition to a piece of legislation that's being considered. You want to pay attention to the bill's progress through the House or Senate and schedule meetings around key events in this cycle. And then don't wait until it's too late. Be vocal early about the issues that you care about, again, so you can be that resource if there are any questions later on. This quote just demonstrates why the patient voice is so important. So it says, the patient voice adds a different perspective to everything that goes on in healthcare and can point out real gaps in the system. So that's your role, and you are the expert on that. So I mentioned a little bit earlier, but we do have some upcoming advocacy opportunities if you are interested. We do have Rare Disease Week, Rare Across America, and State Advocacy Days. So our next event is going to be Rare Across America. Registration is open now, and you can access that from the QR code. Registration will close on July 11th. This is an opportunity to meet either virtually or in your legislator's office. These are your federal legislators while they're back in your home state. So that will happen between August 4th to 15th. It's not meetings all day for those 2 weeks. It's going to be just a few meetings between that time frame. So you're not committing to full day meetings. We also would love if you could keep in mind Rare Disease Week 2026. This will be held in Washington, D.C. next February. Registration will open for that in January. And then Rare Disease State Advocacy Days are held throughout the year around the country. These are a great opportunity for you to meet with your state legislators in their offices. We actually just held one in New Jersey, and then you can find more information about these and register on the EveryLife website. So we also have RDLA webinars. We have monthly webinars that are an opportunity to discuss legislation and developments that affect the rare disease community. We also have quarterly Share Your Story webinars where advocates will receive tips and tricks on how to best tell their story before practicing and receiving feedback from coaches. And then we have those state advocacy webinars where you can learn about the state laws and developments that affect the rare disease community at the state level. So our next RDLA monthly webinar is on Thursday, July 24th from 1 to 2 p.m. You can access the webpage where you can register at that QR code, or you can watch previous recordings of previous RDLA webinars on that page as well. Perfect. So I will go ahead and wrap up there. And I'm curious, Sarita, if anyone has any questions.
We do actually. So the first question that came in, it was actually during the registration process. And that question is, how can first-time advocates identify the right legislator or committee to engage when trying to push for policy? You know, is it something as simple as starting with who's in my district?
That is a fantastic question. So, when you are first starting to advocate, whether that be at the state or federal level, the best first step is to reach out to your representatives to express, your opinion or share your story with them. If you are looking for committee-specific bills, you can go to generally the state or federal health committees. Is where most rare disease legislation goes. But if you have any questions about a specific piece of legislation and which committee it's going to go to, you can also reach out to your legislator directly and ask them that.
Perfect. And another question that came in during registration is actually specific to giving testimony. And it says, what are the common mistakes advocates make when giving testimony, and how can you avoid those?
That is a fantastic question. So, going in and giving testimony can be really daunting, especially when you're new to advocacy. So, one of our biggest recommendations is just to practice beforehand, practice sharing your story. But one of the most common, I would say, mistakes is the balance of fact and emotion. So it's a really difficult balance to find. But if you can find that balance between sharing your story and sharing all of those important emotional aspects of why legislation is going to impact you, but also share a little bit about the data behind legislation or specific action items that legislators can take, that's going to be a really impactful way that you can communicate with your legislator.
Good stuff. And I did a quick stop share just so I can check the Q&A and the chat. I didn't see any other questions there. But if anybody has any other questions for Kendly, you can drop those in. And Kenny, I'm going to go ahead and move forward to your last slide with your contact
Perfect.
information.
Thank you so much, Sarita. And yes, if anyone has any questions, please don't hesitate to reach out to me. I'm always happy to discuss or answer questions. And then we would love if you could follow us on social media. And if you want information about those programs or the webinars, you can sign up for our newsletter, action alerts, and event invitations at rareadvocates.org. Thank you so much.
Thank you. Thank you. All right, guys. So we're going to move forward. We are just a few minutes ahead, but we're going to keep things going and possibly have just a little bit more discussion time, or maybe even give you a few minutes of your day back. And so this next session is being led by Trinisha Williams, a certified midwife, public health leader, and founder of Haven Midwifery Collective. Trinisha has decades of experience in maternal health and community-based advocacy. She is a passionate voice for equity, family-centered care, and systemic change. In this session, Trinisha will explore how maternal health directly affects families' well-being, advocacy engagement, and care outcomes, and how we can use data to shape more inclusive policy solutions. And so we're going to welcome Trinisha Williams to our virtual stage.
Good morning, everyone. Thank you. Thank you, Ms. Jones, for that helpful information on advocacy, because that's definitely part of the work that even I do. So thank you for that. Let me just figure out how to share. All right. I hope everyone can see my screen. Let me start from the beginning. Okay, there we go. All right. So my name is Trinisha Williams. I am a certified midwife practicing in New York and New Jersey. And I'm here to talk to you guys a little bit about maternal health, particularly how we can use data to help leverage change. So some of the outline for this presentation will be define what maternal health is and explain its significance, understand the key disparities in maternal health and outcomes, especially amongst Black birthing people, interpret the data and what those health inequities could mean, and particularly in certain areas of the country, as well as insurance coverage, and understanding systematic responses and gaps in healthcare coverage, especially exploring how we can improve health equity through the use of data. So before I begin talking a little bit about health equity as it relates to maternal health, I want you all to take a moment And imagine bringing life into the world only to face a system that doesn't protect yours. For far too many Black mothers or birthing people, this is truly a reality. What is maternal health and why does it matter? Maternal health is defined as women or people who are birthing, or particularly in the childbirth or postpartum period. The importance is and the importance is looking at the infant survival rate, particularly long term, as well as family health and community well-being. Some of the key indicators of this is maternal morbidity, mortality, and access to prenatal care. And I want us to we will be highlighting why access is a big issue. So since we're talking about data here, I want to sort of focus on some of the numbers. In 2023, the CDC looked at maternal mortality, and it looked at a graph that particularly looked at the stark disparities in maternal mortality and rated them by race and ethnicity in the United States, in which they were able to discover some pretty frightening information. That Black women had the highest rate at 50.3 deaths per 100,000 live births. And this is compared to white women who had 14.5. Compare that to Hispanic women who had about 12.4, and Asian women which had 10.7. The second graph in the bottom is pretty alarming when you look at the images of pregnant people. The purple people are the Black birthing people, and the gray people are the white birthing people. So that we can notice from this graph that Black women are 243% higher to die from childbirth or related issues than white women. Just want us to take a moment, make sure we're understanding and you're taking this in. Some of the key health indicators are how many of us know someone who has had a difficult pregnancy or birth. Personally, in the line of work that I do, I've ran into a lot of birthing people who have had trauma. And I'm not talking about folks that are just had their baby a year ago. I've talked to women that have had their babies 40 years ago and have stories upon how they felt as though they weren't treated fairly or how things were done to them that they didn't ask for. One of the newest things in the news are coming up is about a lot of brown people, particularly Hispanic women, who are being incarcerated and being having their fertility taken away from them without them knowing. It is real. Some women are experiencing these things, and whether or not we talk about them or bring them to the light is a question. What do you think your role could be in some of this data and how we can shape health outcomes? We know how to do things differently, but there's a lot of things in the system that don't allow us to be able to have better outcomes. So you might be asking yourself why maternal health is overlooked in Black communities. This is a long-range issue. Particularly, there's a lot of historical negligence and systematic racism in healthcare. Some of us remember or have done our little research and are aware of stuff like the Tuskegee Institute, where we knew there was a cure for syphilis, and yet we allowed people to suffer and die from the sequela of the disease. We also need to look at how systems are not designed for folks who have less equity, and how people who have other comorbidities may not have had that comorbidity resolved prior to entering pregnancy. There's also concerns about implicit bias and lack of cultural competency understanding. I know I personally find in my practice that sometimes things can be said without saying things, and sometimes birthing people can understand what they need and be able to relay that message to their provider without saying anything. Sometimes it's a gesture, sometimes it's a look, sometimes it's a cultural revelation about something similar, and they are able to sort of bond with their provider based upon other cultural understandings. And then some folks have a lot of biases about what they think. If you see a birthing person who has, 5 or 7 babies, you may feel a certain kind of way about what they may be doing to the system or what they may not be able to give, whether they're Black, white, or indifferent. And we have to look at our own biases and how that's affecting how we give care to birthing people. According to the CDC, over 80% of pregnancy-related deaths are preventable. Yet Black women remain 3 times more likely to die from pregnancy-related causes than that of white women. This disparity persists even when controlling for income, education, pointing at systematic issues like bias and lack of cultural competency care. I know I could sit here and tell you story after story of birthing people who had trauma, whether their names are someone like Serena Williams, who you may be familiar with, or Kira Johnson. These are both brown people who came into grave circumstances through their pregnancy, and we're grateful that some survived and some didn't. In New York City alone, we have had a lot of birthing people run into a lot of trouble. Recently, I've been in contact with families that have lost loved ones. One of the latest loved ones we lost here in New York was Christina Fields, who died from a preventable cesarean section postpartum hemorrhage. When we have things that happen, when brown people are not doing well after birth or literally not making it through, what are we doing to change the systems? We also need to understand that there's underrepresentation in clinical research as well as policy decisions when we're talking about people who are not of the Caucasian hue. What the data shows us: maternal mortality, particularly Black women, are 3 times more likely to die from a pregnancy-related cause than white women. There is severe maternal morbidity, in which they're 2 more times more likely to die if they're Black than white women. And this also affects their newborn, their infant, in which their infant mortality can be 2.9 times higher if they're born to a Black birthing person. The other big issue is insurance coverage. Insurance is often undercovered. One thing I find a lot in my practice is that people who have Medicaid-based insurances often cannot get the same access of care as someone who has a private-based insurance, depending on the state in which they live in. And the services that are available vary from state to state, and that affects how birthing people can get access to care, particularly access to midwifery care. And this disparity does not stop when we come into rural areas in which there are very limited OBGYNs and certain hospitals or prenatal care. I know in my state of New York, which people think we have tons of people, we have 22 counties in which there's not an OBGYN or midwife provider. That's a lot of people who are not being served. And what is that doing for the health for those folks that don't have someone there? And there's other parts of our country where we have rural areas in which we don't have these providers available. What is happening to those birthing people? So the roles that healthcare systems and policies can play. The first thing is that we need to get access. Healthcare systems are essential for ensuring that women birthing people have access to necessary maternal care services through their pregnancy. We also want to make sure that we have efficient healthcare policies that can be able to help enhance the care for the expecting families. We want to make sure that there is supportive staff that is available for those birthing people throughout their pregnancy journey. One of the big things that we have been able to see through the data is mental health and its stressors on pregnancy, birth, and postpartum. Particularly 40% of Black birthing people experience maternal mental health symptoms such as depression, anxiety, trauma related to the stress during their pregnancy, or even they can have emotional changes in their pregnancy. Particularly, they're 4 times more likely to experience PTSD than other counterparts. They can also have different stress management issues in which they may not be able to handle certain types of stress. There is a lot of fear and stigma around their birth, particularly that if they don't comply to whatever is being said, that they're more likely to be reported to welfare agencies such as ATS or whatever their local child services and whatever it's called in their local area, to report them for not being compliant to whatever's being asked of them, and in which they now need to sort of follow up with another level of authority. There's also people not understanding different cultural relevance, whether that is as simple as, I know some cultures like to put a string on the baby when they're born, and some hospitals are not open to that, or moms wanting to have their placenta to take with them when they leave the hospital. Sometimes that can get them in a little bit of trouble with the institution if they don't agree with whatever cultural practices that they like to have happen. The other issue is that they need to be seeking support. There are high rates of suicide and overdose because of different drug uses that can cause maternal death, particularly in the first year of life, that we don't always relate to the birthing experience. There is a little bit of hope out there. We could be able to work with our local community programs in order to be able to help reach these birthing people and offer them services. We can offer them crucial things to help them promote and understand maternal health, particularly in underserved areas, ensuring that the mother and the baby and the partner know exactly what to look out for and how to best care for themselves throughout that period, particularly in the postpartum. We can also educate them, whether that be childbirth education, newborn care, or other types of resources, breastfeeding, so this way they have the knowledge and information to do better in their pregnancy and birth. If they don't have the information, then how can they be able to provide what they need for their baby and themselves? We also need to give them better access to care, particularly improving services and outreach that is available for the care that they need. And sometimes for some people, it is hard. I know I've talked to a lot of birthing people in different states. So you find out you're pregnant, you call and get an appointment, they're talking 6 to 8 weeks before you can see a provider. That's pretty far. And for some people, that could be a lot for them, especially if they have other medical issues that haven't been resolved and now they've got a pregnancy on board. What needs to be done? We need to expand Medicaid and insurance access, that's private insurance access, to low-income folks, whether they're Black, white, or whatever. We need to get better access for those underinsured individuals. And as most of you know, health insurance is under attack. And whether or not we'll be able to continue to provide it is of question because of what's going on right now in the current administration. We need to invest in Black-led maternal health care initiatives, whether or not that is someone from that community that may have a way to reach those folks, or we invest in those local people to have the access they need to be able to care for their folks. We know that there's untreated medical mental issues that in the US can be as much as $14 billion annually. And that's about $32,000 per mother infant care. You probably have heard of people not being able to have good access to mental health services. And in birth, it only gets more dramatic. We need more providers out there that can give this care and better healthcare coverage for those people who are seeking those care. I know in my line of work, even if I find a therapist for a family, oftentimes there's some sort of copayment because they're underpaid. Therapists need to be valued and they need to be paid equitably so we can get that type of care to more birthing people. We need to have more training about anti-racism, trauma-informed care. I know some of my families have had births in certain facilities and have been traumatized by the things that the providers and staff have said or done to them, and in which they do not want to seek out that type of care again. We need to be able to train those providers about biases. We have several states that are looking into laws to make sure that OBGYN, as well as midwives and PAs and all types of OBGYN providers have access to understanding cultural competency care, understanding their own biases, and making sure they're not causing trauma to that birthing person. We need to use data to be able to try to change and improve policies. I know in my home state of New York, we currently have a bill on the table that would allow us to evaluate episiotomy rates and be able to go after those providers that are doing those too often. And if we all are aware of what episiotomy is, it's an incision that is made between the vagina and the rectum to enlarge the vaginal area to allow the baby to be born. And some providers do this routinely for every single birth. And for some moms, that causes a lot of trauma. Oh, and the other thing about episiotomies is they're not always medically necessary. For the most part, they should only be done at about 3% of all births, but we have higher rates with certain providers, depending on how their training was or what they believe should be happening. How do healthcare systems respond? We need to think about how we can expand Medicaid, not cut Medicaid. We need to look at postpartum coverage. One of the things that was recently introduced in my state was making sure that people can have maternity care up until 12 weeks after they deliver a baby. We need to think about 1 year and for most states. And I know that is a healthcare cost, but that will be able to help us save these birthing people, not just brown birthing people, but all birthing people. We need to look at community centers and midwifery-led models so that we can localize the care. If we look at other industrialized nations and how they're offering care, we have better access to midwifery-based care and be able to have better access to community health programs to educate people locally on the ground so that this way they can get the information they need, hopefully prior to pregnancy. We also need to look at gaps in fragmented care. We need to look at the data and transparency and make sure that we're not underfunding our rural areas. Our rural communities do not have enough healthcare providers. And then for the providers we do have there, they may be overworked because of the population that they need to serve. Here are some of my references in case anybody needed to know about them. And now it's our time for questions and answers. I've also enclosed my social media handles if anybody wanted to follow me. Let's see if there's any questions. No, I don't see any. Are there any questions out there?
Let's see. So I do have a couple of questions that came in the beginning. And I know we have, we're completely ahead of schedule. So I want to take a quick second to just kind of highlight, why maternal health was so important to us as an organization. I know for myself, a lot of our families receive our diagnosis of trisomy 18 in utero. And so there's an interconnectedness when it comes to maternal health and why it was important to us bringing it to the rare disease conversation. And then, I'm wrapping up my doctoral program, and maternal health is one of the areas that I wanted to focus on in terms of research. And I learned a lot of the information that you just shared, and it's one of those things to where I saw a connect between being diagnosed in utero and the impact of that maternal health on mothers, but then to look at the stats of what's happening in terms of just mortality and morbidity when it comes to maternal health, it's conversations that I don't know if I'm just, ignorant to those conversations or if they're just not happening. And so I thought that it was just so important to have you be a part of today's conversation. And I'm so grateful that you were available to share, just even midwifery. And I'm probably saying that so wrong, but
it's okay. You got it.
But even that and the importance of it. And so let me just jump to the questions. The first one was, what type of programs or changes in policy would positively impact maternal health the most?
Yeah, that's a great question. We have I'm also president of the American Association of Birth Centers, and us, along with two other groups, have 3 federal bills that are currently on the floor, waiting for more support from our congressmen and our senators to support them. And these bills are looking at 3 different things. One is to allow TRICARE. I don't know if you guys know, TRICARE is a public insurance for people who are in the armed services to cover midwifery-based care. They do not want to cover it for certain types of midwives. So I need you to understand, especially me in New York, do have, and if people like New York City, there's no military base. We do have one in Staten Island. And I've had some families call me that have TRICARE. They cannot use their insurance. They have to pay cash. And that could be a hardship for these people who are serving our country. So we need to get TRICARE covered. The second one would be able to fund more midwifery education, just like we have a GI bill in the past, or we pay for residents to learn medicine. We have no pathway to pay for midwives to learn midwifery. So we need to have more midwifery-based education. In the United States, we have about 14,000 midwives. We underestimate how that is to be able to care for birthing people. We say that midwives should probably be caring for all of his families, and that would probably be about 70% of the births. We don't have enough people to do this. So the second bill would fund midwifery-based education. And we have three types of midwives in the United States, which gets very confusing for most folks. But unfortunately, systemic racism caused that to occur. We used to only have one pathway. And somewhere in the early 1900s, we deemed the granny midwives, the people who used to be enslaved and still practice midwifery for their plantation owners, to no longer continue to practice. And when that disenfranchisement happened, it then ruled midwifery to not be a legitimate career or education or pathway, in which it then needed to sort of get its validity through nursing. And that created three different ways that in which people can become midwives. So that's another big concern. The third bill would look at funding birth centers. We know that in the United States, we have probably a little over 500 birth centers. That's not enough to care for every birthing person that would need that basic level care. And if the person becomes high risk, we all understand how to transfer them to maternal fetal medicine or OBGYN for care. It's only in this country that when we need maternity-based care, that we start at the highest level provider. It's sort of like saying you need to have, a physical exam, and you're going to a cardiologist. Like the cardiologist is like, I'm not going to look. No, you need to go to a regular primary care provider. But in pregnancy, we start at the highest level of care. And until you deliver, you can still be high risk until you just deliver and just stay with that mode. And most other industrialized nations, whether it be New Zealand or Holland or London, wherever it is, we don't do that. We let regular maternity care start with those low risk providers and then move them up if they have a medical need for it.
Yeah, that's a lot
It's
of
a lot.
information.
And a lot of people don't think about maternity care, maternity services until they're in it. And when I have conversations with pregnant people about coverage, I literally, this morning, 9 o'clock, a person has an insurance that in which the insurance will not pay for this type of care. And she was shocked and dismayed and wants to do something to advocate for change. But the problem is pregnancy is only 40 weeks. So most times by you getting active, and just like our speaker before, it could take years for policies to change. So then you deliver a baby, you're now nursing or caring for a newborn. You don't have time to keep going back and forth with your legislator about this. So you move on until you get to the next pregnancy. And I myself have been around long enough doing this work that I've had families that have come to the next pregnancy and like, you're right, Trinisha, we discussed this in my last pregnancy that I was going to talk to blah and blah and blah to try to change it. And now here I am pregnant again and nothing happens. So it's a short-lived period that in which the person should be engaged to want to make change. And if that person moves on, then they move on. Then you might be asking, well, why don't the providers that give this care get more involved in it? I tell people, I don't get paid, or most providers, it's like any other job. You don't get paid to advocate. So for us to make a full-time job, although I volunteer in many organizations to push the change, but most providers are like, if you don't have the money, I don't really care. Like, I'm moving on. Either you have the insurance coverage or you have the money. I can't continue to, take people basically for free to offer care. I tell people, if you went to an auto mechanic and you had a flat tire and standing right in front of them, they wouldn't say, you know what, I'm going to change your tire just because it's flat. They're like, no, push your car down the road. But in maternity care, you want your provider to offer you the care and give you the care, even though you don't have the money to pay for the services. And at some point, it can bankrupt them. I know I'm part of a large home birth community in New York City, and we have all said that maternity care is given on our backs. We offer care to birthing people for 40 weeks, sometimes as much as a whole year, and then we'll receive payment. That's a lot to ask someone to do something knowing that you may not get paid for months. So there needs to be a lot of changes in this system. And until we get those changes, it's not going to move ourselves forward. And until we look at the biases that some providers have and understanding different cultures and what they think their culture should want to do, whether something as simple as some cultures when the baby's born, they want to touch the cheek because they think it's going to put a dimple in. Every culture has something unique, and I can go into a lot of stuff. And you just need to be open and respectful of that culture and what they want to do instead of saying, no, we can't do that. And, because every person needs to be heard and valued. And if they're not, that can affect the way that they're receiving care.
Yeah. I think you raise a really good point too, just talking about, you don't get paid to be an advocate. I even as an advocate, I hear that from patient communities, and that's one concern that a lot of communities have, that, sometimes they're being asked to lend their voice to things. They're being asked to be a part of something and they're not being compensated for it. And a lot of times organizations or big pharma companies, they, they will reach out and solicit your support and want you to be a part of this big project or whatever. And patients are like, no, I know that I can help move this forward, but you're a big entity with a lot of times, financial resources, but you're not giving back to the patient community financially, but you're expecting me to lend my voices. And so I found that, it's fascinating to me that's the same perspective on this side of it as well. Like it takes a toll. I think, regardless of where you're standing, it takes a lot to be an advocate. And it does get tiring. It does get weary.
And
It
relating this
does
back
become a
to
lot
the
sometimes.
and relating this back to the perinatal testing. If you can't get access to care, then you're not going to have these trisomy tests. It's just not going to happen. And I need us to
Yeah.
sit while we're sitting here and talking. There are people in some states that cannot get access to care. So they're going to have a baby, particularly with a disorder that they could at least be informed about or make a choice about and have information about. But they probably will not because they can't get access to care. So they can't get access to the test that will let them know about this for their baby.
Yeah, yeah. Oh wow, that's so good. The next question that came in was in what ways can maternal health data be better integrated into rare disease advocacy efforts? And I think I just gave one example in terms of our rare condition being diagnosed probably 90% of the time in utero. And so what would you say to that? How can maternal health data be better integrated when we think about rare disease advocacy specifically?
Well, I think it can be better integrated by us looking at the numbers and comparing it, looking at who is getting the care and those people who aren't getting the care. What disease processes are we unraveling? The question is, who's going to pay for us to sort through this data and actually look at it? The numbers are out there. Every state keeps track of who is being diagnosed. We need to look back at those people being diagnosed and looking at when their access point was to care and how they were able to get that care. Because if their access was at birth, literally, I'm pregnant, I'm coming to the hospital and delivering my baby, I never had any testing. That's different than someone who came at 5 weeks of pregnancy and knew the whole entire pregnancy, what was going on and what they could be educated about and how they can be prepared for this process. And that intersection could be gravely understood. And now the other thing is, how do we, once we diagnose families, how do we better support them? Because we know when we have a child with an illness, it can put strain on the relationship, not just on the mom and the partner and mental health, but the relationship itself. And how is that going to allow the family unit with any other babies to then be able to sort of move themselves and have this new baby into their home?
Mm-hmm. Good response. There was one other question. How can advocates address cultural and systemic barriers that often prevent mothers, especially those from marginalized communities, from being heard?
Yeah, that is a big issue. What we have done is there are some tools out there that have been devised. One is called the Earth app, and it's IRTH, so birth without the B. And it took out the bias, the B for bias, to be able to help people. And that is a free app you can download, or you can go on their website. And what we're asking for and for folks to do is write down about their experiences, whether it was Dr. A, D, or E, whatever state you're in, write about your birth experiences. And what they're doing is collecting that data. And in some municipalities, they are going back into those providers and talking about the care that client received in order to elicit change. So that's one of the only thing that I know of nationally that's kind of going on. And that was a private person, Kimberly Fields. She thought of that. I'm saying it wrong. Kimberly Seals Elder thought of that. Her and her family came up with that app to be able to help birthing people. And what I can do is I'll put it in the chat in a second so that everybody can see it. They need to get the link to that. And that would be able to be the best way to be able to let folks know about what they experience, whether it's just an OB visit or midwife visit, whoever it is, a visit, or it is your actual birth and when you go in. And you need to think about writing a letter to the hospital about what it was that you experienced, especially if you got a diagnosis and it wasn't favorable and you didn't feel as though the staff gave you the support you needed, or what types of interventions you think could be better. I know it's a lot, but you should write a letter to the institution and let them see how they may be able to render change. Because if you as a family experience that, the next family will experience it too. Most of these institutions want to do better, but they don't have the information or know where they misstepped. So if you let them know, they can be able to make those changes.
That's a really good response. And I do have just one last question. In terms of midwifery, I think is how you pronounce it.
Yeah, midwifery.
In terms of that being for just your basic, there's no challenges or high risk or anything. Would that be something available to a mom of advanced maternal age, or would advanced maternal age be considered a high-risk pregnancy?
So it all kind of depends. Just being over 35, because that's what they call advanced maternal age, is not the reason. There has to be something else. You can still get care from the midwife. So do you have diabetes? Or do you have hypertension? Do you have, I don't know, lupus? There's other things that have to be there. Just being over 35 is not enough. And also not just having IVF treatment. Sometimes people think, well, I had some sort of infertility issue and now I still need to be seen by the high risk provider. There is opportunities for you to be being seen in a conjunction with both, and which some people like that congruent care, and which you can have the low risk model so you can get the information and access you need. One of the things midwives pride themselves on is giving great information and education about what is happening. And sometimes your providers with the shorter visits are unable to relay that information. So sometimes people will go to the MFM or the OB every trimester and stick with the low risk provider throughout the pregnancy. But I also need you to remember 70% of birthing people deliver at a hospital system. And in most hospital systems, there's some sort of OB provider that can be there to oversee if something starts to go awry.
Good stuff. Awesome. Awesome. Let me just double check the chat real quick and Q&A. Awesome. Good stuff. Well, I appreciate you, Trinisha. Any final thoughts before we move on to the next session?
I would just say, I would encourage all folks to think about what maternal care means to you and what you can do locally in your area. There may be access issues that you're not familiar with. And I'll put the Earth app in the chat in a second. Thank you guys so much for your time today.
Thank you. Thank you. Thank you. All right, I'm going to do a quick screen share. So our last session, we're going to be talking about breaking the silence, the impact of mental health on patients and their families. We have the privilege of hearing from Dr. Ashley Perkins, a pharmacist, author, and the co-founder of We Matter Too Incorporated. Dr. Ashley's work focuses on giving voice to patients and families with a strong emphasis on mental health, identity, and systemic support. Today, Dr. Ashley will guide us through how mental health data and lived experiences can work hand in hand to reduce stigma, drive services, and create space for healing and advocacy. So, Dr. Ashley, I will turn it over to you.
All right, thank you. So, as I was trying to think about how I wanted to go about this, I could go in so many different directions. But first, let me introduce myself. I became an advocate about 6 years ago after I went through my own personal experience with mental health discrimination. And generally, when I talk about mental health, I talk about discrimination too, because it happens so frequently. And because it happens so frequently, we have a tendency to allow it to happen just because it's hard for us to recognize, because many people do it in a joking way. So, when we talk about stereotypes, we talk about an idea or a characteristic that we describe an entire group of individuals by. A prejudice is believing that stereotype without taking the time to further investigate or research what those people or what that mental health might look like. that is a prejudice. And the second you put it into action, where you use that prejudice as a way of, describing somebody, or to separate somebody out, or to isolate somebody, that's discrimination. And that's how easy it is to do, discrimination when it comes to mental health. I try to tell people, focus on the action, not the person, not something the person has, or something the person deal with, or they navigate. It's really important to focus on the actions or what the person is doing instead of those pieces. In the United States, approximately 1 in 5 adults deal with some form of mental health issue. Whether it's a minor issue or a major issue, 1 in 5 adults. Suicide is the second leading cause of death in young adults. So when we're looking at the age range between they say about like 6 to 10, all the way up to 18, 24 years of age, it's the second leading cause of death. When we get into adults, or the overall, it's the 12th leading cause of death in the United States. So, mental health affects pretty much all of us. And the thing is that it's not so much just a medical condition. I tell people, you got to look at why. You've got to talk to people why. Because right now, in the environment in which our current political landscape is in, the stresses that people are currently undergoing because of all of this will lead to mental health issues, because of what we're dealing with. It was mentioned that Medicaid and insurance is currently under attack. People are currently not sure what the future of their healthcare insurance is going to be. That is a stress that is going to cause anxiety. It is going to cause depression. If people have societal issues that are being forced upon them, then mental health issues are more likely to occur. It does not have to be just a medical issue. People get, when you're getting when you get this information while you're pregnant about the fact that your child could possibly have a rare disease, that is going to add stress. I don't think people take the time to really look at what affects our mental health and what will contribute to our mental health declining. And it truly is that simple. Many times, the news and journalists and things like this, when they're reporting on somebody dying by suicide, or when we hear about a mass casualty that has been affected by a single shooter, when we hear about these things and people bring up mental health as the cause, which is done more times than not, people associate those things with mental health. And then they're like, well, I don't want to be the person to say I have those issues, because I don't want someone to assume I'm going to cause a mass casualty, or I don't want to be the person who, they associate crazy or insane, or any of those words that we hear people put negative connotations to. People don't want to be seen in that light. And that's why stereotypes and stigma is so harmful. There's so much data out there to show that those who do a mass casualty, they may struggle with their mental health, but that is not the reason behind it. People with mental health issues are more likely to be harmed than they are to cause harm. a lot of times when you hear about police officers or other people who are in the hospital um, who come into contact with patients who have mental health issues, more times than not, when somebody is being more violent, it's because they feel threatened. They are protecting themselves. They are trying to defend themselves from whatever perceived um, threat to them could be occurring. So data is really important in this because data shows us that the stigma, it's not true. It's skewed in this way that shows us, if you just listen to the news, you hear all these negative things, but then you read the research and you see the data and you know it's not that. And I think people should use more data to bolster their arguments, so to speak. When I wrote my book, I knew if I'm going to write a book about mental health and my journey with mental health and all the struggles I've gone through, I knew it needed to be backed up with research, because the more likely people are going to take me seriously, they're going to take me seriously if I have that research and that data to back it up. Also, when we talk about medical professionals, unfortunately, medical professionals are more times than not the ones who are biased against the exact people that they are there to help. There is a research study that I'm in the process of my own doctoral project, and I was looking into implicit biases. And when we talk about explicit biases versus implicit biases, explicit biases are those biases that we are aware of, that we are, very knowledgeable about, and we are making sure we're not enacting. But those implicit biases are those ones that kind of hide in the background. And when you're under stress, or when you're under undue pressure, and you're frustrated, or whatever the case may be, you're more likely to enact those implicit biases because they're more likely to pop out in moments of stress. And so a group of medical professionals were asked, are you biased? And 25% of them admitted bias. And then they had them do an implicit bias test against chronic illness and disability. And it came back that close to 75% of those people have implicit biases against people with disability and chronic illnesses. And that's a massive problem, because medical professionals need to be listening to their patients and hearing their patients. And that's where I think we can use data the most, is being knowledgeable ourselves on the things that we're dealing with, and the barriers that we're coming up against. Because if we don't understand it, how can we have a conversation with our medical professional about them, where we're not only taken seriously because of what we're dealing with, we're also taken seriously on, I'm actually having pain, or I'm actually dealing with this situation. So when it comes to mental health, you can bolster data personally with your own medical professionals, but you can also use it in advocacy spaces to make yourself, sound, hey, I've got this background and I have this data backing me up. I'm someone to be taken seriously. So I always tell people, especially parents who are trying to advocate for their children in education spaces, and in school, know what you're talking about, know the rules, know the laws, know as much as you can know. So when you go into those meetings with people, they will take you seriously, and that you're not going to back down. because it's really important that you do that so that people are taking you seriously. So hold on just a second. Let me close my door. I apologize. Go. Sorry, my dog came in. I apologize. So yeah, so the data's there, but you also have to remember when we're talking about mental health, expect those numbers to be low. Again, people don't want to admit they have these problems. They don't want to talk about these problems. So even though the data is there, the likelihood that even the data that we have access to is more than likely probably going to be under estimating. So when I look at numbers of like how many people seek help and then seek treatment, it's about 60% of those who have mental health issues will seek treatment. I figure that's probably low because there's way more patients out there who need help and need treatment, but really aren't going to go and seek that treatment. Also, rural areas. In rural areas, you're lucky if you have a therapist that's available. And if there is a therapist in a rural area, the odds of them being able to treat the amount of people in the area is very low. They're going to get overworked, and there's going to be long waiting lines, diagnosis. You hear a lot about people self-diagnosing certain things because access to getting diagnosis is not only difficult, but it's also expensive. Even if insurance covers it, you're looking at sometimes autism specifically. If you go to get a diagnosis for autism, it's a couple $1,000s, and that's through insurance. When I was diagnosed a few years ago, it was through our insurance, and it was like $1,500 to go through the process with insurance. So you'll hear a lot of times people are self-diagnosing because access to diagnoses is not accessible. So that is why the peer support system and the community, and we do bolster social media heavily for the disability, chronic illness, mental health communities, because sometimes that's the only access people have. They may not be able to get in to get treatment, but if they're able to self-identify what they're dealing with, then they can navigate life through that lens. And sometimes they're able to learn how to cope or navigate in ways that they can at least do on their own, instead of having doing it through channels like medical professionals and such. So we're very fortunate that we have the communities that we have so that we are able to help people self-identify. And that's where data comes in, is that if you can utilize that information to self-diagnose yourself, then you're at least part of the way there. And then getting access if you need medication or treatment, that of course will have to go through a medical professional, but you at least have an idea of what you're dealing with, so then you can learn how to navigate it on your own. So I prefer to answer questions. So Sarita, were there any questions that people would like to have answered?
Yes, there are questions. So these first two, they actually came in during registration. The
Okay.
first one is, what data would you consider most effective in capturing burdens faced by rare disease families, and specifically like emotional mental health burdens? What data should people consider looking at?
I was looking the other day just to see like what was out there, and there, I think, is it Global Gene or Gene Global? Like, they have a really great resource website that they include mental health for all of like the rare disease, families and caregivers and all of that. And they had a really nice resource area that I thought was really comprehensive. Um, and I think that's really great. NAMI also has a lot of, NAMI does a really great job. I have it pulled up right now and I'm looking at it. They're really good about the numbers and breaking everything down by like specific identifiers. And that's where like they even go into like what happened in 2020 with COVID, and they go into rural areas and the importance for rural therapists. Like there are many rural areas that don't even have access for mental health, because not only finding somebody to go there, but then if they do go there, that they're usually the only one who is available to those people in those areas. So that's why I make a big that's why I talk about using the social media and having the connection with the community, because that's how many people do it, because they don't get access otherwise.
Yeah, and a huge shout out to Global Genes. They actually are a partner organization of ours. And I sit on one of their leadership councils, one of their leadership committees. And so yeah, a huge shout out to them for having resources online for families specifically in the rare disease space. And I'm very familiar with NAMI. We do a lot of mental health work and within our organization, but also within the community. We work alongside our school district, just looking at just integrating mental health when it comes to children, and specifically for us, siblings of children with medically complex diagnosis. That's what we take to those conversations. And then too, I am a mental health first aid instructor through the National Council of Mental Wellbeing.
Yep.
Specifically, I'm a youth mental health first aid instructor because they have so many different components to the program. And for me, it was just really important. The opportunity, it truly fell into my lap and I jumped on it. And it was just an opportunity to be certified myself, but then the opportunity came to actually be an instructor, and I took it to just provide that mental health support, helping families identify different, red flags, if you will, that their children may be exhibiting. And I know for me specifically, I thought it was, something that I could bring to the rare disease space because, a lot of families are navigating their child with, the medically complex diagnosis and the special health needs, and it's easy to miss something that your other children may be going through.
Yeah.
And so, the hope is this program, this education will help you be a little bit more attentive to these signs and symptoms. And push you toward trying to get help and not necessarily miss it because you're putting so much of your attention somewhere else.
Yeah, and that's why I always mention the why. Like there is generally a why behind most of it, and instead of seeing kids as behavior problems, which is generally what happens, is that they're labeled as a behavior problem when they might just be struggling with something, anxiety, or they may not be diagnosed with autism or ADHD or a lot of those issues that will come off as behavior issues. And so a lot of times when I have a student or anybody who says there's behavior issues, I'm like, but is it a behavior issue, or is it because the child is struggling with something and they don't know how to put the words to what's going on? So that's why many times, Wyatt was diagnosed with autism and ADHD last summer. And a lot of that, when I hear the behavior, I'm like, okay, but is it behavior, or is it because he's overstimulated, or, he just needs to get up and run around the school or something, just get some of that energy out. So many times, and even with adults, I mean, there are times that I'm emotionally over-regulated and all of that stuff, and I just need to go scream,
Yeah.
before I come back. So, a lot of times mental health affects each person differently, and it's more about having the conversation than, like I mentioned, putting them in a little box with a stereotype and, ignoring the issue.
Well, and I think you hit that, I think you touched on that earlier during your talk. How nobody wants to be labeled, that person who's going to do this task or this, this act. And so, and I think to me that highlights the many layers of stigma. It's not just, it's not just, mental health is stigmatized because of this. Like there are so many different layers to the stigma that comes with mental health. We did have another question. How can advocates use mental health data to influence funding decisions or services, service availability? So you touched on how some areas they don't even have a therapist for families to reach out to. How can we use data to try to change that?
So I wish the current environment that we find ourselves in the United States, I wish it were better, because unfortunately, given the way this administration is currently trying to single out specific types, like we've heard that they want to make a list for autism, and we've heard that, they want to go after certain types of medications that people are taking. It's not impossible. It's just more difficult because they're doing the whole "you're not worthy if." And a lot of people are struggling with that because they don't want to be put on a list. They don't want their medications to be. I've been fighting in Florida for the past few months. Our state government is trying to get access to all of the prescriptions that were filled in 2024 to have people's names and date of births and physician information. And they're hiding behind a bill specifically about transparency of billing when it comes to insurance companies. So, on the face, it's something that we really want to be done, but at the same time, they're asking for information that we're like, why do you need that information? And people are worried because they're not being transparent about it. We ask, why do you need this information? And nobody wants to tell us why that information is necessary. And being a pharmacist, I know what goes into billing. So it's this fine line of, we want certain things and certain entities to be held accountable, but what are you doing on the back end with too much information? And when it comes to advocacy, you have to, and it's going to depend on the state. In highly red states where they aren't as accepting of different, it's harder to get information to them versus states where it's a little bit more of a mix and people are more willing to bring the mental health in. And I hate that this is all tied so much to the political makeup, but unfortunately it is, because what we see right now is the attack on it versus the acceptance of it. And again, in Florida, like, we are very skewed to the red, and the policymakers in Florida that I have been in contact with about this whole issue are all Democrats. They're all the ones that are more open to hearing, we don't want this oversight and we don't want them having too much of our medical information. And do I think it's impossible? No, but it just makes it more challenging when the federal policymakers have such a negative and closed-minded thought about all of it. And people don't want to admit it right now because they're afraid of what's going to happen. And I really can't blame anybody. I really can't. Because you don't know what they're going to do with that information. So it's a time like no other. And it's because I am so tapped into the disability advocacy area, a lot of people are worried and they're just concerned. And I'd say do what you feel you can do and the amount of risk you feel like you can take on. Especially if you are going to share personal information about yourself. For me, they can, if they're going to lock me up, they're going to lock me up. I have accepted that amount of risk, but not everybody can accept that amount of risk. And so it really does matter how far are you willing to push, how much, how many waves are you willing to make? Because I mean, I made a joke the other day. I'm probably on a list somewhere because I haven't let this insurance thing go. And it really is just what we're living in right now. And I hope it gets better, but I'm also right now not hopeful either. So,
And I think that adds to the already concern that a lot of patients and families have when it comes to research participation and and lending their voice to a lot of different conversations. I think a lot of people were already concerned about, well, how is my information being used? I know we hear that a lot when it comes to clinical trials and different things. People want to know. I mean, things as simple as newborn screening, and the dry blood spots. There's just always a concern about, even if this information is de-identified, what does that mean for me? And I think the current climate just heightens that concern and that alarm, and is making people more and more hesitant, if you will, when it comes to navigating the healthcare ecosystem. So
yeah, absolutely. Yeah. And I mean, we saw a lot of it too after Roe versus Wade was overturned, and the states getting, like Florida has the strictest, we're 6 weeks. And, and that was the concern that a lot of people, are they screening for the types of medications they're using for an abortion? Are they looking at trans affirming care? Are they looking at psych meds? Like, what are they doing with the information that they claim they should have access to? And, and that all adds stress and anxiety, and mental health already is something that people deal with, and you're adding all of this other stress on top of it, where you don't know if you're going to have insurance, you don't know if people are going to be monitoring you don't. And that's why I tell people mental health isn't just one thing. It can be so many different things, and it doesn't have to be something that you deal with for the rest of your life either. It could just be situational. And when the situation improves, then, your outlook or your well-being is going to improve. And the supports just aren't, they're there. They're just not, the access is really the problem for most people.
Well, I appreciate you so much, Dr. Ashley, for being here, as always, and just lending us your mental health expertise in this space. How can people reach out to you if they want to connect following this series?
So I am on Twitter, even though it's a dumpster fire, I'm still there. Blue Sky and TikTok are the main ones that I use these days. Because I Matter is the handle for Blue Sky and Twitter. Add a 19 on the end of it for TikTok. And of course, my email is always open to anybody, whoever needs anything. I've helped people navigate, whether it's schools or their health care, because unfortunately it comes in all different forms and types. And yeah, definitely anything people need assistance with.
Perfect. Good stuff. Thank you so much. Thank you for being here. Well, guys, listen, I appreciate everybody who jumped on, and I even appreciate those who I know will, view this on the replay on our YouTube. Thanks for spending the past 2 hours with us. If you'd like to connect or collaborate or continue this work, these conversations, feel free to email us. You can email the E.WE Foundation at info@theewefoundation.org. You can reach out to me directly, Sarita at theewefoundation.org. Social media handle, everyone is we. Mine, social media, Sarita Edwards. You should be able to find me there. You can also jump on our website, theewefoundation.org, to learn more about the work that we do, our impact in the community, and how we are actually putting the work from these conversations in action. A quick reminder before we let you go, this event is approved for 2 CEUs. We'll follow up by email with those who express interest in those. You'll get a certificate in your inbox. The session is recorded. It will, like I've said, will be available on our YouTube channel. Huge thank you to our speakers, Trinisha, Kendly, and Dr. Ashley, for being here with us, sharing your wisdom, your lived experience, and your passion for the work that you're doing in these spaces. Thank you to those who attended, and for being the heart of the movement. We just appreciate you. So until the next one, be rare. See y'all next year.